Is there a way to determine the effect of a treatment or intervention? The answer is yes, using a randomized controlled trial. This video discusses randomized controlled trials, or RCTs, which are research studies that are designed to answer the question, does this treatment work? A well-conducted RCT is one of the study designs that can be used to answer this clinical question. In an RCT, participants are randomly assigned to two or more groups, a treatment group and one or more comparison groups. The treatment group receives the treatment, and the comparison group usually receives an alternative treatment, such as usual care, a placebo treatment, no treatment, or they may be placed on a waiting list. The effect of the treatment is then measured after the treatment is provided, and sometimes over a period of time following the treatment. Let's review the key components of an RCT: randomization, allocation concealment, blinding, outcome measurement, intention to treat analysis, and interpretation of results. In this video, we will focus on the first two key concepts, randomization and allocation concealment. Here is an example. In this RCT, investigators wanted to determine the effect of progressive resistance training in patients with shoulder impingement syndrome compared to a waitlist control group. Most RCTs state their study design in the title, which can make them easy to identify. Okay, let's go a little bit deeper into some of the key features of an RCT. The first is randomization. This means that all participants are randomly assigned to one of two groups, either the treatment or the comparison group. Each participant entering the study has an equal chance of receiving the treatment or not. Think of this like flipping a coin. Every time you flip a coin, you have a 50% chance of heads and a 50% chance of tails. So why is this important? The best way to understand this is to think about what would happen if we didn't randomize participants. Pretend you are testing a new drug for heart disease. As the researcher, you are responsible for putting participants into two groups, one receiving the real drug and the other receiving a placebo pill, and you intend to measure who suffers a heart attack. You have a lot invested in this new drug and you really want it to work. As participants are enrolled, you may be tempted to put patients who are healthier and therefore less likely to experience the outcome, a heart attack, into the treatment group and patients who aren't as healthy into the placebo group. The results may suggest that those who received the new drug were less likely to suffer heart attacks, but we would never know whether it was the drug that saved those people or whether they were less likely to have a heart attack to begin with. The only way to truly know if the reduction in heart attacks is due to your new treatment is if both groups of participants were exactly alike in every way before they got the treatment. When we randomize participants and every participant has an equal opportunity to receive the new medication or the placebo treatment, we have a better chance of balancing the two groups with respect to the likelihood that they will experience a heart attack. When the groups are balanced, we can expect to see similar characteristics between the groups. It is important that these characteristics should be known key prognostic factors of the outcome. So if our outcome is the number of heart attacks that each of our groups experienced, it would be important to know the participant's age, health status, and lifestyle behaviors, for example. This concept is also very important when we have an RCT with a relatively small sample, because balanced groups are harder to achieve with small sample sizes, even if randomization was done properly. So if the sample size is small, it is even more important that we see how balanced the groups are on the key prognostic factors. Randomization can be achieved by creating a list of random numbers ahead of time, or in its simplest form, flipping a coin or rolling a die as participants enter the study. For randomization to work, the researcher responsible for putting participants into groups should have no knowledge of which treatment group is coming up next in the sequence. For example, if we are flipping a coin, the researcher would have no way of knowing whether the result will be heads or tails for each participant. Alternatively, if there is a pre-generated list of treatment allocations, the researcher should not have access to this list. This is called allocation concealment, and it maintains the integrity of the randomization process. To see if randomization was successful, we can compare the two groups before they received the treatment. In most studies, this information is found in Table 1. Authors will usually list a number of prognostic factors such as demographic and clinical characteristics in the first column, and a second column containing the values within each group. Sometimes studies will list p-values beside these values. However, p-values are related to sample size and cannot indicate how the difference will impact the treatment effect. The way we determine differences between groups is by eyeballing the values and knowing something about the prognostic factor itself. For each prognostic factor listed, ask yourself, are the differences between these groups likely to impact the outcome we are interested in? In our example, a group of participants with shoulder pain were randomized to receive either the treatment, resistance training, or the comparison, waitlist. When we look at Table 1 in this study, we can see that the two groups are similar in age, duration of pain, and pain intensity before receiving the treatment. This means that randomization and allocation concealment was likely well done. Now we can be more confident in saying that the results of this study are actually due to the intervention that the patients received. We can then look at the outcomes and compare between the groups. Is there a difference or no difference between the groups? Did the treatment work? Randomization does have disadvantages. A large number of participants is often required, and this can be expensive. RCTs are a very useful study design. Though there are some disadvantages, their unique design features allows us to answer the important question, does this treatment work?